Today, I'm going to talk about a very important topic, shock. With the patients of shock, while working in emergency department, you can come across a patient with various symptoms. So, this is a very important topic and I need you to focus on what I'm saying. Let's get an overview of a shock. Shock, by definition, is when oxygen demands and metabolic demands are not being met by the cardiac output. When you think of a shock, think of a bigger picture, because shock involves multiple organs. In simple words, shock can be a global phenomenon. For example, a patient can present to you with acute myocardial infarction, or a patient can present to you after a trauma. A patient who is bedridden can present to you with various types of shocks. To begin with, shock is usually associated with hypotension. But with shock with hypotension, that means the state is decompensated shock. It's usually decompensated shock when the patient presents in an emergency department. But in very rare cases, there might be shock with hypertension. With hypertension, you can have hypertension emergency or carbon monoxide poisoning. But the take-home point from here, and by the end of this lecture, is just one statement: early recognition and urgent intervention. With this, you can save the patient. Before we move on, let's review a simple concept. This is a cardiac index or oxygen delivery. And this formula indicates the oxygen delivery inside a body system. Next is cardiac output, that's stroke volume into heart rate. Well, to be precise, stroke volume is the amount of blood that's been ejected in every cycle. And that determines the cardiac output. And this cardiac output has very serious role in all types of shocks. So, what are the causes of the shocks? There are multiple. As I mentioned before, again, what causes decrease in oxygen supply or increased metabolic demands that have not been met by the cardiac output that leads to shock? There are multiple things to be taken care of while dealing with a patient with a shock. First thing, what is the cause of the shock? And it is very difficult to know at times because a patient can present with any symptom. So, first and the foremost thing, what are the causes of the shock? To begin with, for example, a patient comes to you after a road traffic accident and his blood pressure is less than 90/60. So think of a fluid loss. With a road traffic accident, there are very chances that there is a greater amount of blood loss. So it can be post-hemorrhage or fluid loss. That leads to hypovolemia. What that means is, for example, let me get back to you on the screen. So following loss of 2 liters of blood, you have decreased amount of volume inside your blood vessels. So by that, what I mean is that with the loss of 2 liters of blood, there is a hypovolemia inside your intravascular compartment. So with that, I mean you have an intravascular volume depletion. This is what is known as hypovolemia. Moving back again. Fluid loss, hypovolemia. Next, a patient comes to you with chest pain or shortness of breath or extensive sweating or nausea or vomiting. Think of an MI. Think of a myocardial infarction. With myocardial infarction, patient can progress into heart failure. How that happens? Go back again. A patient with previous history of MI. He presents to you with severe shortness of breath. He cannot breathe. And with previous history includes his ejection fraction is decreased. Ejection fraction is less than 25%, for example. How do you think his contractility would be? Definitely it would decrease. And it would decrease to a certain amount that he cannot pump blood out of his heart efficiently. So what happened next is blood pools up inside your heart. When it pools up inside your heart, it goes back where it's coming from, primarily pulmonary vasculatures, leading to orthopnea, shortness of breath, and features of acute heart failure. And that's what you call cardiogenic shock. So, moving on again. Anaphylaxis. Anaphylaxis is a severe allergic reaction. It's IgE stimulated receptors that cause anaphylactic reactions. A patient can present to you with tachycardia, rash, wheeze, multiple symptoms that you can come across. With anaphylaxia, you can have an allergic reaction with this that can lead to a shock. Neurogenic impulses, sepsis, these all leads to vasodilation. Let's go back and how these leads to vasodilation. As I told you, anaphylaxis, sepsis, they release certain amounts of cytokines. These cytokines have a definite role in our body. These are pro-inflammatory mediators. What cytokines have to do? Increase permeability of vessels. What this is, when there is increased permeability, the blood or intravascular volume that leaks into extracellular fluid or extracellular space, leading to depletion of intravascular volume. That leads to shock. With myocardial infarction, as I told you before, with a cardiogenic shock, there is decreased cardiac output. And why is that? Because of decreased pumping of the heart, and that's a pump failure. Other reason might be a valvular disorders. You can have mitral regurgitation, mitral stenosis, aortic regurgitation, and aortic stenosis, or valves involving right heart of the right heart. With decreased cardiac output, there is severe chances that you can have decreased oxygen supply to the organ. Going back again to first slide, I said to you what the shock is when there is increased oxygen demand that's not been met by the cardiac output. So with hypoperfusion, decreased oxygen supply to any organ leads to hypoxia. Hypoxia leads to cell anoxia. Cell anoxia is when cells are deprived of oxygen. Cell anoxia is, as I told you before, is decreased oxygen supply to the cells. Leads to a hypoxic condition inside. But that leads into pro-inflammatory mediators. As I mentioned before, pro-inflammatory mediators, mainly cytokines. As I move ahead, cytokines, interleukins, what they do is they increase the vascular permeability, leading to intravascular volume leak to the extracellular space. And most of the time, it can present with edema. Acidosis. Cell anoxia, as I told you again, it's the same concept. With increased permeability, there is a decrease in intravascular volume. With a decrease in intravascular volume, hypovolemia occurs. And that's decreased fluid or fluid levels inside the intravascular compartment. There are severe chances of thrombosis and edema. Also, there are chances of hemorrhage as well, and heart failure. Well, in many books, it's been written that cytokines, especially released from pancreas, decrease the activity of myocardium in the heart. Shock can lead to renal failure. And how do you as a working and as emergency physician can speculate the patient is going into renal shutdown? Most important thing, decrease urinary output. Gastrointestinal lesions. With decreased cardiac output, with the patient in a shock, there is decreased blood supply to many organs. So a patient can present you with abdominal pain, suggesting you an abdominal ischemia. Lung failure. As I mentioned before, with heart failure, especially the left ventricular failure, the blood pools inside your heart and goes where it is coming, where it goes back where it is coming from, into the lungs, pulmonary vasculature, leading to pulmonary edema or orthopnea, and patient might present with orthopnea, shortness of breath, and tachypnea, or increased heart rate. End result, if not treated quickly and adequately, can result to cardiopulmonary failure. So, before going on, a patient, while you're working in emergency department, a patient with shock can present to you with various symptoms. And it's hard for a physician to understand and to make a diagnosis out of the symptoms that he's presenting with. A patient can present with severe diaphoresis, or excessive sweating, or chest pain, or shortness of breath, or difficulty breathing, or the shock, the organs that has been affected by the shock, they can present with the symptoms of that organ. So, can present with impaired organ function. For example, again, myocardial infarction, patient might present to you with orthopnea, acute heart failure symptoms, with renal shutdown, decreased urine output. Hypotension is an obvious sign. As I told you before, early on this lecture, that shock with hypotension, you can say it's a decompensated shock. Hypotension is a very, very important indicator. Alteration in mental status. Patient can present to you in a situation where you cannot identify or you cannot take any history from that patient because he has an altered mental status at that time. He is confused. The patient can be drowsy. The patient can be irritable. So it's hard for you as an emergency physician to work out or to take a history with that patient. And the other limitations with the patient coming with altered mental status, you cannot completely rely on the caretakers or the families. The history they are providing you, you cannot rely on that. Diaphoresis, I told you again. A patient with MI or myocardial infarction can present to you with diaphoresis, excessive sweating. It can present to you with chest pain, central chest pain. It can present to you with the symptoms of cardiac failure. shortness of breath, pulmonary edema, peripheral edema, increased respiratory rate, decreased blood pressure, difficulty breathing, again, multiple reasons for difficulty breathing, anaphylaxis, allergic reaction, cardiac failure, pneumonia, multiple infections involving lungs can present to you with difficulty breathing. Tachypnea, increased respiratory rate, agonal respiration, abdominal pain. As I mentioned before, with hypoperfusion of multiple organs in the shock, a patient can present with the symptoms involving that particular organ. If there is decreased oxygen supply to abdomen, it's an organ ischemia, it's abdominal ischemia. So a patient might present with abdominal pain, vomiting, and constipation as well. Low urinary output. It is said in a patient with shock, or while you're resuscitating a patient with a shock, it must be around 0.5 ml per kg per hour. The urine output should be 0.5 milliliter per kg per hour. So with the renal shutdown, low urinary output, because the prime function of the kidneys is to excrete urine. A patient can present to you with cold, clammy, and motile skin. When you touch the patient, it can give you an idea this patient can be in shock. Before moving on, first and the foremost thing I told you at the beginning of the lecture, the take-home point is to early recognize and to early treat. You must be having a general approach to a patient with a shock. When a patient comes to you with the symptoms that I told you before, think of a shock and you need to make a decision as soon as possible. History. Sometimes a patient comes to you with altered mental status or chest pain. He cannot speak, he cannot talk, or he's severely tachypnic. It's very difficult while working in as an emergency physician how to take history from that patient. And the caretakers that are coming along or the family members won't provide you enough information that you can sense that it can be a shock. But history is really important. First thing and the foremost thing, time, course, and the progression of the disease. A very, very important topic to know, thing to know in ER. When did the symptoms started and how it's progressing? Is it worse? And what are the associated symptoms with it? Medications. For example, a patient is on beta blockers or calcium channel blockers, or he's taking digoxin, or he's immunosuppressive, he's immunocompromised. Needs to be evaluated because beta blockers, calcium channel blockers, they can all reduce heart and cardiac contractility. Pre-existing condition, multiple. Look for any previous cardiac history, cardiac MIs. Look for any terminal diseases, cancers, tumors. Look for end-stage renal diseases. Pre-existing disease, stroke. A patient with a stroke, with elderly patient with a stroke are usually, most of the times, bedridden. Look for it. Look for bed sores. Look for multiple things that can give you a hint that this patient can be in shock. Most of the times, elderly males or females who are bedridden are with on Foley's catheter or for monitoring of the urinary output or being catheterized. That's the very, very important source of infection. Or urinary tract infection can lead to sepsis and septic shocks. These are very important things to know. Next, Social history. Is the patient on any drugs? Is taking any drugs? Is the patient has a history of rehabilitations before? Trauma, road traffic accident, history of fall. These are the very, very important point to know. Before going on moving ahead, many of the times a physician in emergency department cannot recognize the possible cause or possible reasons why the patient is having these symptoms, even though the patient is shot. But even if you don't have any cause of it or you don't know what's going on with the patient, start the treatment as soon as possible. Because if you wait for a reason, if you wait for anything, any substantial thing that can lead to you a diagnosis, that will be late for a patient. So if you have an unverified diagnosis, go for the treatment. Go for treatment. Well, this is a very, very important slide. It's not just related to shock. Any diseases, while you're working in emergency department, you need to memorize and keep on remembering again and again. It's a simple five letters, A, B, C, D, and E. But it has to do a lot more for the safety of the patient and the cure of the patient. A is for airway, B is for breathing, C is for circulation, D is for disability, and E is for exposure. I need to emphasize on this. With A, B, and C, that means airway, breathing, and circulation, you can determine the cardiopulmonary reserve with these three alphabets. With airway, you can see the ability of a patient who can breathe. With breathing is how the patient is breathing. Is it a shallow breathing? Is he tachypnic? Is he putting more effort to breathe in? And circulation, pressures, how the fluid is circulating and which organ is being perfused adequately. Physical examination. Before moving on, before even doing physical examination, again, look for airway, breathing, circulation. These are the most important determinants that can lead to prognosis and that can make sure that prognosis of the patient with shock is very, very good. Physical sign includes vitals. Vitals include blood pressure, temperature, pulse rate, respiratory rate, and saturations. And these determinants give you a lot of information that you can start the treatment, you can start making diagnosis, and you can start thinking what is the first step to do in this patient. Heart rate. The patient can be tachycardic, or the patient might be dysarrhythmic, irregular heart rates, irregular heart rhythms. The patient can be bradycardic, heart rate less than 60. Respiratory rate, patient might be tachypnic, increased respiratory rate. Blood pressure, a very, very important thing. I will put more emphasis on this later on in this lecture. Pulse rate, pulse oximetry, saturations. With pulse, you need to identify it's a regular rhythm or it's an irregular rhythm. Temperature. These 6 determinants can provide you with a very, very good information about this patient. Before moving on, I want to explain it a bit further. Heart rate. As I mentioned before, you need to know what's the heart rate is. Is it bradycardic, decreased heart rate, or increased heart rate? Or with increased heart rate, you can recognize the heart is putting more effort to pump the blood. What happens is when there is increased heart rate, with increased heart rate, there's increased myocardial oxygen demand because the myocardium has to work very fast on this. And with this increased oxygen demand, the symptoms of the shock worsens because there is decreased oxygen supply. Respiratory rate. You need to have respiratory rate of a patient as soon as possible because that might show you many things. For example, is the patient is tachypneic, increased respiratory rate. So that means there is decrease in oxygen supply inside to the organs. And with this, the patient is putting more effort just to grab as more oxygen as the patient can. Blood pressure, mean arterial pressure, I'll explain more in the next slides. Pulse, oximetry. Why is oximetry so important? Because if the patient is with decreased oxygen supply to the organs, the first and the foremost thing, as a physician, you need to supply the patient with an oxygen. And how do we do that? Let's come later in this lecture. But for now, the most important point, you need to provide a patient with external oxygen. So, mean arterial pressure. It's one of the components of the vital signs that we take a patient with a shock. How do we calculate it? It's diastolic blood pressure plus 1/3 of the difference between systolic and diastolic blood pressure. It needs more discussion. Moving back to widescreen. So, mean arterial pressure is related to preload and afterload. These are the most important determinants for mean arterial pressure. What is preload? Preload, in simple words, is end diastolic volume. End diastolic volume is the volume that's inside the heart chambers before systole occurs. So, preload is decreased when there is hypovolemia. And why is so? For example, a patient, as I told you before, with the road traffic accident, preload is equal to end diastolic volume. With road traffic accident, person loses 2 liters of blood. What happens then? With 2 liters of blood, with 2 liters of external hemorrhage, there is decreased intravascular fluid levels. And when there is decreased intravascular fluid levels, there is decreased venous return. And when there is decreased venous return, there is decreased blood in the chambers of the heart, eventually leading to decreased end diastolic volume. So, the main determinant of end diastolic volume must be venous return. Venous return decreases with the loss of blood or hemorrhage. So, further about preload. As I mentioned before, it's a determinant of end diastolic volume. And end diastolic volume depends on venous return. With decreased venous return, as I mentioned before, with hypovolemia or blood loss or hemorrhage, there's decreased venous return coming into the heart, leading to decreased end-diastolic volume. With decreased end-diastolic volume, there is decreased cardiac output. Decreased cardiac output leading to organ ischemia and organ hyperperfusion. And the patient might present to you with symptoms of that organ failure. Before moving on, I give you a scenario. A 65 years of age male, known case of diabetic, hypertensive, previously ischemic heart disease, present to you with shortness of breath and features of acute heart failure. While you are running through his record, you come across a 2D echo, and that shows ejection fraction of 25%. What will happen to preload at that time? So coming back again. For example, 100 mils is ejected per cycle. This is a hypothetical in normal individuals. With EF or ejection fraction, with ejection fraction of 60%. So what will happen? And 100 mils is being pumped out with ejection fraction of 60%. What will happen if ejection fraction is decreased? Less than 25%. Obviously, there will be decreased cardiac output, even though the venous return will be adequate. But the heart has a pumping defect. It cannot pump a blood adequately outside the heart. So what will happen is decreased cardiac output, decreased perfusion, and one more thing. When there is decreased cardiac output, the end diastolic volume increases. And why is that? Because if 100 mils with EF 60% is ejected, what will happen with EF 25%? Obviously, it will decrease. So, for example, 25 ml is being pumped. What remains inside? 75 mLs. So with the next cycle, same venous return, 100 mils is coming again. Next cycle, it turns out to be 175 ml. And why is that? Because this 75 ml that could not be pumped because of a pumping defect stays inside the heart, and it's add-on on the venous return that coming on the next cycle. So leading to 175. What will happen next? With the same ejection fraction of 25%, how much amount of blood will be ejected? Let's say 50 mLs. Let's say 50. Remaining 125. And with the next cycle, it turns out to be 225, and the cycle moves on. So why is the reason to explain all of this? So when this 225 mils pulls inside a human heart, it goes back to where it's coming from, pulmonary vasculature. With going back to pulmonary vasculature, the patient might present or presents with acute heart failure, signs and symptoms of acute heart failure. And what is the most important cause of a patient with decreased ejection fraction? It's a myocardial infarction. That's the most important point. So that was about preload. Next, afterload. What do you mean by afterload? It's the force that is required to pump the blood out of the body, out of the heart. This force has to cross a resistance that's been offered by the vessels. So the main determinant of preload is systemic vascular resistance. This is a good concept, an interesting concept to understand. For example, this is a vessel with a diameter of 10 and 100 mils cross through vasculature with 2 power. That's an hypothetical example. What if this and resistance is dependent on this diameter and the radius of the vasculature? It's the most important determinant of vascular resistance is this radius, this diameter. So what if we increase systemic vascular resistance? By this, it means this radius would decrease. So, with radius decrease, can you think this 100 mils will go easily? No. It needs more power, a power of 4. So this resistance that's been offered to the blood by the vessels is called afterload. And the main determinant, as I said before, is systemic vascular resistance. Why I'm emphasizing on preload and afterload? Because these are the two very, very important determinants of mean arterial pressure. And for example, in a patient with acute heart failure, you must have to decrease the preload and the afterload. Moving on to diagnostic testing. There are 2 types of diagnostic testing that I think can happen in a patient with a shock. With a bedside, and it can be case to case. With bedside analysis, first and the foremost thing, look for blood sugars. Blood sugar analysis. ABGs, arterial blood gases. What would arterial blood gases show? pH. If it's acidotic or alkalotic. If the patient is retaining carbon dioxide or excreting more carbon dioxide. Is the bicarbonates levels too high or too low? The simple test can give you much information. Chest radiograph. Why is this patient breathing so fast? Is in a pulmonary edema? Is there any pneumonic patch? Or if there is a tension pneumothorax or a lung collapse? There are multiple information that you can get from a just simple chest radiograph. ECG, MI, rule out ischemic heart disease, rule out an infarction, rule out any blocks. With a simple ECG that might not take more than 5 minutes can give you much information. Metabolic profile, complete blood count. And why is this complete blood count so important? It can provide you with information about white count, hematocrit, hemoglobin levels, and platelet counts. Why is hemoglobin level and hematocrit too important? As I mentioned before, a patient with road traffic accident or excessive bleeding or excessive hemorrhage, there will be decreased hemoglobin levels inside and increase or decrease hematocrit. So that needs to be treated as soon as possible, because with decreased hemoglobin, there is decreased oxygen supply to the organs. Because the prime function for hemoglobin is to deliver oxygen to the organs. Urine analysis. Can show you a patient with urosepsis or patient with urinary tract infection, if that's the cause of this patient with septic shock or not. Then it's case-to-case screening. As I mentioned before, there are multiple reasons a patient can present with. A tox screen would give you much information. Urine pregnancy test, blood and urine cultures, cardiac profiles. As I said, ECG, it shows anything leading to ischemia or give you indication of ischemia. Cardiac profile, troponins, CKMB, can provide you with information about a cardiac heart attack. Endocrine screening. Lactate levels. Lactate levels have some prognostic value as well. It can provide you with information about the prognosis of the patient with a shock. Ultrasound. Well, in many countries where emergency departments are well established, there is a bedside ultrasound. It can give you a very, very important information and within no time. For example, it can give you information about pericardial effusion, pericardial tamponade, pneumothorax. It can give you information about tension pneumothorax. Or it can give you information of a patient with abdominal pain. It can provide information about abdominal aortic aneurysms. It can provide you with information about ejection fraction or cardiac contractility. Or it can provide you with intra-abdominal fluid. For example, a patient comes to you after following a history of fall, and you cannot find any external hemorrhage, but the patient is still going into hypotension. Look for intra-abdominal blood loss, and ultrasound will provide you information within no time. And thus, ultrasound also guide you for central venous lines. Moving on. Differential diagnosis. As I mentioned before, at the start of this lecture, the shock can be due to a various reasons. It can be due to heart, cardiogenic shock, fluid loss or hemorrhage, hypovolemia, hypovolemic shock. It can be due to spinal cord injuries, neurogenic shock. It can be due to infection leading to sepsis and septic shock. It can be due to pneumothorax and decreased obstructive blood supply to the heart. That can be intention pneumothorax, pulmonary embolism, cardiac tamponade. So these are the determinants while you deal with a patient of a shock. Central venous pressure. Central venous pressure is the pressure inside the central line. Systemic vascular resistance and cardiac output. That's cardiac index. First, hypovolemia. Again, blood loss, fluid loss, hemorrhage, decreased intravascular fluid. What will happen to central venous pressure? It will decrease. Oxygen carrying capacity would decrease. Systemic vascular resistance would increase. That can be compensatory. And cardiac output decreases due to decreased venous return. Cardiogenic, you can have a normal or increased central venous pressure. And why is that? Because I told you before, the patient is in volume overload. The cardiac muscles cannot pump the blood adequately out of the heart, leading to increased pooling inside the intravascular compartments. So the central venous pressure can be stable or normal, or can increase. Systemic vascular resistance would increase, and the cardiac output would decrease. Why is cardiac output decreased with increased central venous pressure? Again, because the cardiac muscles cannot pump blood adequately. Next is distributive. It has two types, septic and anaphylactic. With sepsis, you have decreased central venous pressure. Why is there a decreased central venous pressure? You can have a normal central venous pressure with sepsis as well, but usually it's with decreased central venous pressure. Why is that? Because of vasodilation. Mentioned before, at the start of this lecture, the cytokines, they vasodilate the blood vessels, leading to increased pooling inside the intravascular compartments. There's decreased oxygen carrying capacity. Systemic vascular resistance decreases because of vasodilation. Cardiac output can increase or decrease, depends on the severity of the shock. With anaphylaxis, allergic reaction, you can have decreased central venous pressure, decreased oxygen capacity, decreased systemic vascular resistance, but you can have increased cardiac output. Neurogenic spinal cord injury, sympathetic chain ganglions are being damaged. What happens? No change in central venous pressure, no change in arterial supply. There is decreased systemic vascular resistance. And why is that? Because of neurogenic shock. The sympathetic chains, the sympathetic ganglia are damaged. They cannot maintain the tone inside vessels. And cardiac output might increase or decrease. Obstructive, as I told you before, cardiac tamponade, central venous pressure increases. And why is cardiac tamponade increases central venous pressure? Because what happens is this is the diastolic failure. A patient with cardiac tamponade, the heart cannot fill adequately. The blood, the venous return that's coming inside the heart cannot be filled because of tamponade. When this happens, there's decreased venous return. And eventually, again, there is increased back pooling of the blood because the heart is not pumping adequately, leading to increased central venous pressure, increased arterial oxygen supply, increased systemic vasculature, but decreased cardiac output. Because why? Because this is a diastolic failure, and without an adequate amount of blood during diastole, you cannot have an adequate cardiac output. Tension pneumothorax can present with decreased or increased cardiac central venous pressure. Same goes to arterial oxygen supply. Systemic vascular resistance might increase, and there might be decrease in cardiac output. With obstructive shock, what happens is there is decreased blood supply to the heart. With decreased blood supply to the heart, there is decreased contractility or inadequate contractility of the cardiac muscles. Massive pulmonary embolism, increased central venous pressure, increased systemic vascular resistance, and decreased cardiac output. Again, the blood supply to the heart is compromised because of the massive embolus that's present in pulmonary vasculature. Classification. Mentioned before in the previous slide, there are 5 different types of shocks: neurogenic, cardiogenic, hypovolemic, obstructive, and distributive. So shock, again, classified into hypovolemic shock. The most important cause, hemorrhage, fluid loss, or dehydration, excessive dehydration. Cardiogenic shock, pump failure. Why is this pumping failure? Because of myocardial ischemia, leading to decreased cardiac contractility. Valvular disorders, mitral regurgitations, mitral stenosis, aortic regurgitations, aortic stenosis, and most valves involving right heart. Cardiac dysarrhythmias. Explain a bit further again. While working in an emergency department, you come across a patient who is restless, who is tachypneic, who has a heart rate of more than 200 and a blood pressure of less than 90/60. And when you see the rhythm of that patient, it shows ventricular tachycardia or ventricular fibrillation. So how does this bring a cardiogenic shock? With dysarrhythmias or ventricular fibrillation or ventricular tachycardia, there is decreased time for ventricles to fill during diastolic phase. When this happens, the chambers in the heart remains empty, and the cardiac output, the pumping cardiac output decreases, leading to cardiogenic shock. Distributive shock again, septic shock and anaphylactic shock, sepsis, anaphylaxis, intoxications. With neurogenic shock, I told you before, it's injury to sympathetic ganglions in the spinal cord. With acute spinal cord injury, there might be there is increased parasympathetic activity because there is decreased sympathetic activity. With increased parasympathetic activity, there is vasodilation, there is bradycardia, or patient might present with hypotension again. Spinal cord injury, obstructive shock, tension pneumothorax, massive pulmonary embolism, cardiac tamponade. These are the various types, including obstructive shock. And severe pulmonary hypertension again. Severe valvular stenosis can sometimes lead to obstructive shock. Hypovolemic shock. Much have been told before in this lecture. It's an outline, flowchart. Hypovolemia, decreased venous return. Why? Because of intravascular fluid loss. With decreased intravascular fluid loss, decreased venous return, and eventually decreased preload. With decreased preload, there is decreased cardiac output. Why is that? Because cardiac output, as I told before, it's dependent on stroke volume and heart rate. What happens to cardiac output with decreased venous return? With decreased end-diastolic volume, there is decreased systolic volume. With decreased systolic volume, there is decreased cardiac output. As you can see this in the equation, cardiac output is dependent on stroke volume and heart rate. With cardiac output decrease, there is hypotension because blood pressure is dependent on cardiac output and total peripheral resistance, leading to tissue hypoxia and perfusion failure, which leads to organ dysfunction and eventually multi-organ failure. Cardiogenic shock, again, multiple reasons. Most important, myocardial infarction. Others include valvular lesions or tamponade. Cardiogenic shock is a shock that is dependent on cardiac activity. What happens is when during a patient with myocardial infarction, with wall hypokinesia, what do you mean by wall hypokinesia? Is because of ischemia or because of myocardial infarction, there is decreased activity or decreased wall motion of cardiac chambers, leading to cardiogenic shock. Why is this wall motion decreased? Because as with myocardial infarction, every wall is being supplied by a particular blood vessels or coronary arteries. With ischemia to specific or a block to a specific coronary artery, that artery that's supplying that wall gets ischemic, and with this, eventually, that wall is being hypoperfused. With this hypoperfusion, eventually leading to decreased contractility of that part. Acute myocardial infarction, as I told you, most important factor. Decreased stroke volume, decreased cardiac output, and hypotension. It needs inotropes and vasopressors. Inotropes increase cardiac contractility. This will be more studied and explained in detail later on in this lecture. Is release inflammatory markers and mediators. Left ventricular end diastolic pressure increases with acute myocardial infarction. And why is that? Because I told you before, because the blood pools inside, because there is decreased cardiac output due to decreased contractility. Heart cannot pump adequate amount of blood from the heart to the body, leading to increased pooling inside the chambers and eventually increasing end diastolic pressure, which eventually pulls back blood where the blood is coming from, is pulmonary vasculature, leading to pulmonary edema and hypoxia. Same release of inflammatory mediators and catecholamines, further worsening shock. What's the mainstay of treatment with acute myocardial infarction? Revascularization, or bypass surgery, or PCI, stenting, dilation of the vessels that been suffered due to an ischemia. Myocardial dysfunction, pump failure, leading to, again, left ventricle end diastolic pressure and decreased stroke volume and cardiac output. Cardiogenic shock. Okay, before going further, as I mentioned before, the release of cytokines and inflammatory mediators can progress to vasoconstriction, which increases myocardial oxygen demand, further worsening cardiogenic shock. Before going further, increased heart rate, mentioned before as well, increases in myocardial oxygen demand. With cardiogenic shock, a patient initially in early on the presentation with the cardiac failure, the patient can be tachycardic, but with further compromise and further cardiogenic shock becomes unresponsive because of decreased oxygen to the heart. Distributive shock. Distributive shock can be of three types. Involves three things: septic shock, anaphylactic shock, and can be due to intoxications. So, distributive shocks, it has nothing to do with cardiac activity. Well, so what's the mainstay of treatment? Adequate fluid therapy. Adequate fluid therapy just to ensure that the intravascular volume is replaced and we have adequate amount of urinary output through kidneys. Again, vessel dilate because of vasodilation that occurs in sepsis, leading to decreased systemic vascular resistance and hypotension. The blood pools inside the vessels, leading to decreased venous return to the heart and eventually decreased cardiac output. Changes in the changes in the vascular structure, leading to eventually vasodilation, and hypotension leads to organ perfusion, decreased organ perfusion. Going back again, capillary leak. Why? Because inflammatory mediators are pro-inflammatory and they increase vascular permeability, leading to vascular fluid leak into the extracellular space. Neurogenic shock. As I told you before, with acute spinal injury or spinal trauma and with sympathetic ganglion injury, there is increased activation of parasympathetic and decreased action of sympathetics. The patient with neurogenic shock presents with hypotension and bradycardia. Why hypotension? Because the tone that is maintained by the sympathetic stimulations is not anymore because of sympathetic injury. And why is bradycardia? Because sympathetic stimulate or increase heart rate. Increase parasympathetic stimulation, decrease sympathetic stimulation, reduced vascular tone, massive vasodilation, again, the same phenomena that was in sepsis, vasodilation, increased pooling inside the vessels, decreased venous return to the heart, and eventually hypotension. Decreased systemic vascular resistance because of vasodilation, diminished cardiac output, and reduced tissue perfusion. Eventually compromised cellular metabolism. So obstructive shock. Obstructive shock is when there is decreased blood supply to the heart vessels. What happens is myocardium contracts against high afterload. As I told you before, afterload is the force that's required to pump the blood out of the heart. So when there is increased systemic vascular resistance, there is increased afterload, and more power is needed to pump the blood across the vessel. Blood pressure leads to venous congestion. Sympathetic overactivity leads to vasoconstriction in order to maintain blood pressure, and vasoconstriction increases systemic vascular resistance. Despite normal blood pressure, organs are poorly perfused due to reduction in blood flow. Okay, that's again a very important part. How to approach a patient with a shock. Again, the take-home point, early recognition and early treatment. Let's revise. At the start of this lecture, I told you, shock is when oxygen and metabolic demands are not met by the cardiac output. So the first thing, oxygen demands are not appropriate, or there is decreased oxygen supply to the organ, leading to hypoperfusion and cell anoxia. The first and the foremost thing a patient needs is an oxygen. So you, working as an emergency department or emergency physician, first and the foremost thing you have to do, oxygen supply. How to supply oxygen? There are different means of delivery of oxygen. Nasal cannula. There are simple prones that supply oxygen with nostrils. It has limitations. It cannot supply oxygen when required more than 5 liters per minute. If we need more oxygen with 5 liters, move on to next, venturi mask. It's a facial mask with venturies. Venturi is of different flow rates, and it can provide you with FiO2 of 0.2 to 0.5. If not, move on to next, that's non-rebreathable mask. It's an oxygen reservoir. It has a bag that's inflated and can be collapsed. It supplies oxygen or FiO2 level of 0.6 to 0.8. Next, in non-invasive positive pressure ventilation. It has some limitations. For non-invasive positive pressure ventilation, patients should be hemodynamically stable and must have a healthy cardiac contractility. If the patient is hemodynamically unstable or the patient is in cardiogenic shock, this won't help much. This is an instrument of choice to deliver oxygen in the patients with increased carbon dioxide levels, but who are hemodynamically stable and with good cardiac contractility. If a patient is hemodynamically unstable and contractility is compromised, one should move on to continuous positive airway pressure and BiPAP. It's called CPAP and a BiPAP. If not, with non-rebreathable mask or limitations with normal positive pressure ventilation, eventually one has to move to mechanical ventilation with invasive techniques. That's endotracheal tube intubation. So when a patient moves from spontaneous breathing to an assisted breathing, there are chances of ventilation perfusion mismatch or VQ mismatch. So initially, with assisted breathing, FiO2 levels should be 1. Before moving on to volume interventions, while in assisted breathing, there is positive and expiratory pressure. It's useful in heart failures and adult respiratory distress syndrome. It's normally started off with 3 to 5 centimeters of water and can be increased to 2 to 3 after 30 minutes. The main limitations of increasing positive and expiratory pressure is increases intrathoracic pressure, but decreases venous return. So coming next to volume interventions. Going back again, volume depletion following a road traffic accident, hemorrhage, fluid loss, dehydration. As an emergency physician, the first thing you need to do after supplying the oxygen, volume replacement with crystalloids. So, fluid therapy or diuretic therapy. Fluid therapy is for volume replacement, and diuretic therapy if it's a patient with acute cardiac failure. So what happens in an acute heart failure? Volume overload. With volume overload, the patient presents to you with orthopnea, shortness of breath, tachypnea, pulmonary edema. There are multiple things a patient can present with. So the first and the foremost thing you do in a patient with acute heart failure is with diuretics. Most commonly and more potently used are loop diuretics, especially furosemide. They decrease the volume overload by excreting and via urine output. Administration of nitrates is also a treatment in acute heart failure, which decreases both preload and afterload, so decreasing cardiac workload and eventually time for cardiac muscles to relax and pump adequately. BNP and opiates, natriuretic peptides and opiates. Opiates should be used very, very cautiously because it can sometimes worsen congestive heart failures. Rotating tourniquets, and eventually dialysis. Patient with shock needs reassessment after every 30 minutes. Or if any intervention you make or any new thing you add to the treatment of that patient, that needs reassessment as soon as possible. Reassessment of urinary output, because if a patient is having an adequate urinary output, it's a sign that diuretics is working at its best. And the patient's renal perfusion is good. It's not going to renal shutdown. So repeating again, what should be the output? It should be the 0.5 mL per kg per hour. Moving on to vasoactive agents. Vasopressors. Before going further, let's go back to whiteboard. We have 3 types of receptors. alpha 1 receptors, beta 1 receptors, and beta 2 receptors. Alpha 1 receptors are present on smooth muscles of the vessels, and conduction system of the heart. Conduction system of heart. So what happens when alpha receptors are excited? In smooth vasculature, it causes vasoconstriction, and increased excitations of cardiac conduction system, increased excitation. With beta 1, these are also present in smooth vessels, but primarily in myocardium of heart and conduction system. While beta 1 agonist, they increase the contractility of myocardium and increase excitation. Beta 2 are receptors present in smooth vessel wall, and bronchial muscles. With activations of beta 2 receptors, it leads to vasodilation and bronchial dilation. Why is this important to know these receptors? Because vasopressors or inotropic agents, they work on this receptor to increase the cardiac contractility or vessel constriction or vasoconstrictions. Back again. Vasopressors, first line agents. Phenylephrine, it's purely alpha 1 agonist. What it does is, as I mentioned before, alpha 1 receptors, vasoconstriction, and increase cardiac conduction excitations. But to use phenylephrine, there should be increased heart rate and good contractility, because the side effect of phenylephrine is bradycardia. And that's the dose, 0.2 mics per kg per minute. Next is norepinephrine. It's a very, very useful drug. It is a drug of choice in septic shocks, in cardiogenic shocks, or in anaphylactic shock. Norepinephrine is also an alpha 1 agonist. It depends on the dose the patient is receiving, because at low doses, it increases cardiac output and increases systemic vascular resistance. But in high doses, it only increases systemic vascular resistance. Next, we move on to dopamine. The dose is 3 mics per kg per minute. Dopamine is beta receptor agonist. At low doses, it increases cardiac output and decreases systemic vascular resistance. And high doses, it only increases systemic vascular resistance. It is also used in cardiogenic shock with systolic blood pressure of 70 to 90. The worst side effect of dopamine is it causes pulmonary vasoconstriction. So vasopressors to be continued. Second line agents includes vasopressin, 0.04 units per minute, and epinephrine, 0.02 mics per kg per minute. Well, the problem with epinephrine is, though it's a very important and very potent cardiac stimulator, it increases heart rate, which increases myocardial oxygen demand, and it's arrhythmogenic. It increases the risk of ventricular tachyarrhythmias. The most important use of epinephrine in a patient with cardiac arrest. Inotropic agents. Inotropic agents primarily increase the cardiac contractility. The most important one first-line agent is dobutamine. The dose is 3 mics per kg per minute. Dobutamine has beta receptor agonist activity. It's beta 1 stimulant and it's more potent than dopamine, increases cardiac contractility and decreases systemic vascular resistance. Opposite to dopamine, it causes pulmonary vascular dilation. Second, dopamine, as I mentioned before. Second line agents includes epinephrine and milrinone. It is a phosphodiesterase inhibitor, which has similar effect of beta agonist. It's a second line drug in cardiogenic shock, when especially we need an inotropic agent, and it's useful in the patients with end-stage renal liver diseases. So blood transfusion. 2 packed of RBCs increases hemoglobin levels to 25% and hematocrit rate to 225%. Going back to the example again, patient with profuse hemorrhage or blood loss after a road traffic accident. He needs blood. Why? Because he needs hemoglobin to carry oxygen to the vital organs. Increase hemoglobin by 25%, 2 PRBCs, and increase hematocrit rate from 225%, and thus increases oxygen carrying capacity inside human body. Blood transfusion is always required in a patient who has increased blood loss after a hemorrhage or a fluid loss. But before even transfusing blood, a patient with fluid loss or hemorrhage should be given at least 2 liters of crystallite as soon as possible, because that is what is required to increase the intravascular volume. But what happens in a patient with congestive heart failure? With congestive heart failure, you need to have an hematocrit rate for more than 30%. Again, why? Because of an adequate and sufficient amount of oxygen to be delivered to the vital organs. Suspected cardiogenic shock. Why? Multiple reasons. Told you before as well, dysarrhythmias, myocardial infarction, decreased contractility, valvular lesions, cardiac tamponade, all lead to cardiogenic shock. Decreased activity of cardiac muscles, leading to decreased cardiac output, decreased venous return, and cardiac tamponade. These all cause you cardiogenic shock. What interventions are required? First, need to know if it's cardiogenic or not. Acute cardiogenic syndrome shock should be monitored by blood pressure, heart rate, and respiratory rate. The mainstay of treatment, revascularization. If a patient with acute heart attack or acute MI, he should be straight away sent to cath lab for intervention or cardiothoracic surgery for coronary artery bypass surgery. These are the mainstay of treatment. A patient comes to you in ED, emergency department. First, if you're suspecting an acute MI, the first and the foremost thing give him aspirin, high dose of statin and anticoagulant, clopidogrel, surgery for simple vessel coronary artery disease, or a patient who cannot undergo primary PCI or percutaneous interventions, go for surgery. Avoid beta blockers, ACE inhibitors in acute phase of cardiogenic shock. Beta blockers, why? Why beta blockers? To be avoided in patients with cardiogenic shock, because, as I mentioned before, beta 1 receptors are the increased cardiac contractility, but when we give beta blockers, these are beta antagonists and decrease cardiac contractility, further worsening cardiogenic shock. So patients should be given hemodynamic support, which includes inotropes, vasopressors, and oxygen delivery. If not, can be undergo left ventricular aortic balloon dilation and biventricular aortic balloon dilation. Next, moving on. Need to be medical therapy for congestive heart failure. Should be given steroids, TPA for massive pulmonary embolism, leading to right ventricular failure. With massive pulmonary embolism, there is decreased blood to the heart vasculature, leading to right ventricular failure. So either a patient should be given TPA, or if contraindications are present for TPA, proceed for thrombectomy. Pulmonary hypertension should be treated as soon as possible, and pulmonary hypertension causing right ventricular failure should be treated early as well. With aortic stenosis, you might need ballooning of aortic valves, and this can help you in relieving cardiogenic shock. So, end of this lecture. First, at the end of this lecture, I would like you to remember a few points, a very, very important point. This is how you approach a patient. And if not, you lose the patient in no time. So some pearls and pitfalls. What happens if you fail to recognize a patient with a shock? Failure to recognize a shock can lead to a patient death in no minute. Early recognition is very, very essential and important while you're working in an emergency department. Early ventilator support. Why? Going back again to the first slide, oxygen demands are not being met by the cardiac output, or decreased oxygen levels because of hemorrhage. If you don't provide with external oxygen supply, the patient can go into respiratory and cardiopulmonary compromise, and eventually you lose the patient. Inadequate fluid resuscitation, especially in patients with hypovolemia or septic shock. If you don't do it in time, you lose a patient within no time. Delay in administration of empiric broad-spectrum antibiotics. It is said in the books that in the patient with a sepsis or septic shock, the first 6 hours are very crucial. Empiric antibiotics should be given in the first 6 hours. Failure to continue hemodynamically parameters. That includes heart rate, respiratory rate, blood pressure, temperature, and saturations. Improper selection of vasoactive agents. The problem with vasoactive agents are most of them are arrhythmogenic, can lead to fatal arrhythmias if not monitored again and again. Reliance on pulse oximetry. Why is this an important point? Because a patient with a cardiogenic shock, for instance, comes to you and comes in the ER, and he has a cold and clammy skin. With pulse oximetry, you cannot rely on oxygen levels inside because you have a cold skin. The patient is clammy. On the other hand, with the patient with carbon monoxide poisoning, he can have a normal saturations. So it can be a distracting or a misleading for an emergency physician to rely entirely on pulse oximetry. So in the end, let's summarize what we have learned today. Shock, again, decreased oxygen supply, metabolic demands have not been met by the cardiac output. The mainstay of a patient dealing with the shock is how you approach that patient. First of all, go for ABC: airway, breathing, and circulation. Next, oxygen supply. Look for vitals, look for blood pressure, look for oxygen saturations. Do not wait for cause if not found. Start the treatment as soon as possible. Keep mean arterial pressure more than 65, because mean arterial pressure is an indicator for cardiac perfusion and cerebral perfusion. Next, breathing, circulations, appropriate fluid, appropriate volume replacement, appropriate diuresis, hemoglobin replacement, blood transfusion, multiple things. But this is how you approach a patient with a shock. And this is how you can protect a patient from death in a shock. So in the previous slide, as I mentioned, pitfalls, pearls, and failure to do things in the right time, right duration, can eventually lead into patient's death. That's all for today's lecture. Thank you for watching sqadia.com.